Yeah.
So maybe I can just talk a little bit about some general principles of the modeling before I go through the slides. When we look at modeling, I think it's worth saying that modeling is just that. It's a model. It is in no way predictive of what's actually going to happen. And there are a lot of assumptions made about how the virus is transmitted that we don't actually know, and we won't know until this is all settled, maybe 2-3 years from now. So it's kind of like it's guesswork to some degree, but it's an educated guess, and it's based on data and what we do know.
And I'd suggest it gets a little more of an educated guess as we go. Right?
Yes, and the further along we get, the better the data gets, and the more the model can hone in on probably the actual course of things. And one other thing, and we've already spoken to this a little bit, is that, these models are based on what's happened in more urban areas, and so there is a difference between rural and urban. We don't really know, there's no data to suggest if that difference is really quantifiable in a large way or not, but it's all to say that there is some uncertainty around these models. That being said, it's the best that we got, and it's worth looking at to help us guide our plan as we respond. So there was county-specific modeling data from CDPH. As I already pointed out, it's about a month old at this point, and so it does not take into account the actual numbers that we've had over the past month. And so I think it's more useful to talk about some of the modeling we've done at the local level that takes into account the more recent numbers over the past month. And so that's what I'm going to talk about here. So what if we left everything in place, the shelter in order in place for the next 9 months? What would that look like? I'm not suggesting that that's going to happen. This is just for the sake of defining one end of the spectrum, and as Hank called it, a continuum of a response, right? So if we left things in place for the next 9 months, and we ran the simulation, and I should mention that this is with the University of Pennsylvania, their open source model as well, which was chosen for a number of reasons. Someone much smarter than me, our epidemiologist, could go on and on about why. But we've been using this model for a variety of reasons. So if we leave everything in place, this is what we'll see. We see this plays out over a very long time, 9 months here, okay? And then along our y-axis here is the number of patients. And so for each of these curves, this is one point in time in a hospital. Okay, so when we're talking about these numbers, we're talking about one point in time. This is how many people are sitting in a bed. So when we see this number of 145, I'm talking about 145 COVID-19 patients sitting in a hospital bed. Similarly, 64 ICU patients sitting in a bed in a hospital. 38 of them on a ventilator. And up until this point, 28 cumulative deaths. And so this death number does not take into account what happens on the back end here. People continue to die on the back end of the curve as well.
Dr. Ennis, I'm so sorry to interrupt, but I think this there might be some kind of clarification that's helpful. Dr. Frankovich, I was personally myself confused about this slide when I first saw it, and I think Dr. Frankovich cleared it up for me, but maybe you could clear it up for our viewers as well. It's intuitively hard to make sense of the fact that for a week or for a long time, our case count, our positive tests, which is the best measure available to us, I suppose, of the spread of the virus in Humboldt County, has been flat or pretty flat for a long time. So it's hard to sort of intuitively understand why, when our transmission rate seems, by the available data, to be low, to be going down, why there would be a big balloon, a big curve that goes up in December.
Yeah, so I think the curve you're referring to is our actual epi curve locally, and it's looked something like this. Am I correct?
Yeah.
So to put this in perspective,
although the bulk of those people are presumably recovered, or what
Yeah.
we're choosing to call recovered, and so no longer transmitting.
Yeah, so if we could make this a completely closed system and we were able to seal off the county completely and there was no one coming in and everyone stood in place for 14 days, as you jokingly suggested, it's possible that we'd be able to really develop a pure containment strategy. And, you know, we were talking before we got started about New Zealand. They're adopting essentially a pure containment strategy. We don't live in a vacuum. People are coming in and out. People are moving around still. People are in the home, potentially exposing family members if they've tested positive, even though they're isolating. It potentially generates more cases. We don't have the ability to test everyone we want to test. And so there's low-level circulation out in the community right now, even though we're not picking up. It's out in the community.
I mean, I'm sorry, but to really, that point, you know, to really understand how much is out there, we have to be able to do surveillance testing. We have to be able to test everyone who's symptomatic, and we have to be able to test a lot of people who are not. And that would give us a true idea of where we are right now. Our 0 cases don't represent the number of people with COVID in the community. They represent the number of people that we've tested who have COVID. Right. And that's really different.
The other quick thing, oh, I'm sorry, go ahead.
And the testing is strongly biased at this time because we've had to, because of limited testing, we have to prioritize who we test, and it's going to be biased because of that. You know, we know that pre-symptomatic and asymptomatic transmission plays some role, and we thus far have mostly been unable to test those folks.
The other very quick question I have about this slide is the number of ICU beds. You say there that this would be below capacity, but the number I think that's been out there is that there are 27 ICU beds available in Humboldt County, and that seems to be much more than that.
Yeah, so you know, I think later on I'll talk about some of the stuff that I've been doing with the hospitals to build capacity and build surge capacity even outside the hospital walls. And I can speak to that point. I've been working with the hospitals across the county to really expand their own internal plans and try to support them taking care of the sickest people within the hospital. And this is kind of taking a step back to talk about strategy. I'll just use this opportunity to do it now. It doesn't make sense to build a whole new hospital outside of what already exists. That requires a lot of infrastructure. You need to be able to have you know, all the gases in the wall. You need to have a large staff. You need to recreate a lot of processes. So really what makes sense is to make this ICU space critical patients be cared for in the hospital setting. And in effect, you are displacing some other person who could be potentially sitting in that bed. And I don't want to get too far ahead of myself, but that's kind of the working strategy that we've been using, is to enable hospitals to take care of sicker patients, and then we'll create a mechanism to care for maybe the less sick who might be displaced as a result.
And for comparison in there, Hank, I think what you're alluding to is when you look at, you know, our baseline capacity compared to what the hospitals have been able to do, that number of ICU beds comes much closer to that 64 than it is at baseline.
At this point, and we're still working on this, but in general, I would say the hospitals that are capable of caring for ICU level care patients, you know, they've generally tripled. They have plans in the works for tripling their capacity. So this is kind of the far end of the continuum of our bookend here of a potential response. And now on the complete opposite end, let's say that we've put all these orders in place, and then on May 1st, we lift the orders and people go back to behaving like they were prior to COVID-19 ever being in the world. Okay, what would that look like? So we can see here that the curves look generally the same in terms of shape, but I just want to point out a few things. This time scale is about the same, okay, 9 months, and I'll just point out that the other curves were way over here. So we see the curve here with fewer physical distancing orders or facial covering orders in place, we see that this curve gets shifted much sooner. Okay, that is one general conclusion. Additionally, these curves are all on the order of 6 to 7 times higher at peak. Okay, and again, I'll remind you that these numbers represent number of patients sitting in a bed in a hospital. And you know, and I don't think we put this up here necessarily to frighten people, but this is what the model says, and this is based on the best available data. And this is clearly a situation that would overwhelm our hospital capacity several-fold, potentially.
I'm wondering, I'm not sure if everyone is actually being able to watch this as opposed to listen, so I was thinking it might be useful to just talk about the numbers a little on there.
Yeah, thanks for reminding me. So, so what we see for hospital bed occupancy is just shy of 1,000. We have up here 976 patients sitting in a hospital bed.
At one time.
At one time. We have 408 patients sitting in an ICU bed at peak, 251 patients on a ventilator, and up until this point, we have 188 cumulative deaths, okay? And then that does not account for the deaths that occur on the downslope here of this curve. And clearly, this is just far beyond what we are capable of caring for in our community, and far beyond what we could even, with robust surge plan capability, be able to care for. So to put this in perspective, I thought it'd be helpful to put the two curves together on a slide. This just graphically represents, you know, how far apart the curves get pulled, how much flatter the curve is. Out on the far end here, we can see that as time goes on, the curves are separated by several months. One is 6 or 7 times higher, the other one is much lower. There is a line drawn on here for licensed bed capacity at 275, and we can see that the one bookend here of current orders being in place still puts our ability to care for these patients well below the licensed bed capacity. This is just the hospital bed occupancy, so people sitting in a hospital bed. I haven't included the ICU patients sitting in a bed or a vent or deaths, but they're all on the order of about 6 to 7 times higher. And you may ask, why do the deaths go up? Well, it's likening it to the 100-car train. You know, we have a couple breaks on that train. One is the community mitigation orders, the shelter-in-place orders. And that is a strong break. You know, we really stopped in the tracks. That's why we see the curve really flatten down. But as we talk about rolling some of those things back, you know, we're not going to have a very strong break in the setting of limited testing. And so as we talk about modifying the orders, it's really important that we have robust testing in place so we can actually know what's happening in the community, and we can test, we can trace, and we can isolate. That is a huge piece of this that really needs to be in place, along with the 5 other measures in the governor's framework before we take that step, I think.